Glioblastoma, a diagnosis that frightens patients and perplexes physicians and scientists alike. In the 20 years since standard of care was established for this disease, prognosis and median survival have essentially remained unchanged. But while some have seen this as a source of despair, others, here at Penn, at some select centers nationwide, and even globally, have seen an opportunity for innovation. We are at a historic inflection point in neuro-oncology, at the cusp of major paradigm-changing discoveries. Today, I will talk about two of them. Hello everyone, my name is Ogoluwa Faimiwo, and I'm a second-year medical student at the University of Pennsylvania. And today I'm going to be talking about the current landscape of CAR T-cell therapy for glioblastoma, with a special focus on the most recent developments in the field and present and future areas of innovation. In my presentation, I will briefly review the current standard of care for glioblastoma management. I'll talk about how CAR T-cell therapy is changing the treatment paradigm. I'll give an overview of ex vivo production of CAR T-cells and some of the challenges to this method. Finally, I will discuss some of the potential benefits of in vivo production of CAR T-cell therapy for glioblastoma. Chimeric antigen receptor T-cells, otherwise known as CAR T-cells, are currently FDA approved for specific types of blood cancers, including relapsed or refractory multiple myeloma, large B-cell lymphoma, follicular lymphoma, amongst others. While CAR T-cell therapy has shown remarkable success in treating these liquid tumors, solid tumors such as glioblastoma have proven resistant to immunotherapy, largely due to tumor heterogeneity, immunosuppressive environments, the blood-brain barrier, and T-cell exhaustion. The current standard of care for glioblastoma was established by the landmark paper by Roger Stoop and colleagues almost 20 years ago, which defines the current FDA-approved regimen that combines maximal safe tumor resection with radiation and chemotherapy. Gliadel wafers, which delivers chemotherapy directly to the surgical resection cavity, is an FDA-approved adjunct for newly diagnosed and recurrent GBM. In addition to that, the wearable Optune device is another FDA-approved adjunct for new and recurrent glioblastoma, and this delivers tumor treating fields directly to the tumor sites. Still, median survival remains unfavorable. But CAR T-cell therapy for glioblastoma is a new and exciting frontier, and remarkable progress is being made in this space, particularly here at Penn. Recurrent glioblastoma was long thought to be almost untreatable, but CAR T-cell trials are changing that view. Starting off right at home, from the work of Drs. Stephen Bagley and Donald O'Rourke, their phase 1 trial selected 6 patients with IDH wild-type recurrent glioblastoma, and they were treated with a single intraventricular infusion of a bivalent CAR model targeted at epidermal growth factor receptor epitope 806, otherwise known as EGFR epitope 806, and interleukin-13 receptor alpha 2, otherwise known as IL-13R alpha 2. Patients 1 to 3 were treated with a dose of 10 million cells, and patients 4 to 6, 25 million. In all 6 patients, radiographic evidence of tumor regression was seen with MRI 24 to 48 hours after CAR T-cell therapy, and partial tumor regression was maintained in some cases 28 days post-treatment. No toxicities greater than grade 3 were observed, and neurotoxicity was effectively managed with dexamethasone and anakinra. Next, at City of Hope, Dr. Christine Brown and colleagues selected 65 patients with recurrent high-grade multifocal glioma, the majority of which were glioblastoma, and treated them with anti-IL-13R alpha 2 CAR T-cells delivered intratumorally, intraventricularly, or both. Patients were stratified into 5 treatment arms, differentiated by the types of T-cells: central memory T-cells versus central memory and stem cell memory T-cells, and the delivery method. And they received 3 to 4 T-cell injections. There was a statistically improved result for the last treatment arm that received both intratumoral and intraventricular T-cells that were composed of CARs manufactured using stem cell memory and central memory T-cells, compared to the other 4 arms, which were a mixture of delivery methods but only featured CARs manufactured from central memory T-cells. Overall, stable disease was attained in 50% of patients treated across all 5 arms. No dose-limiting toxicities were observed, but 35% of patients had grade 3 or above toxicities. Finally, Dr. Brian Choi and colleagues from Mass General Hospital selected 3 patients with recurrent glioblastoma, and they were treated with a single intraventricular infusion of CAR T cells targeted at wild-type EGFR and mutant EGFR-V3. All 3 patients showed radiographic evidence of rapid tumor regression by day 2 post-CAR T cell therapy, though 2 of the 3 patients had eventual tumor progression. Taking a deep dive on the Penn trial that has been gaining a lot of press for its exciting results from the completion of the phase 1 trial, I'll be discussing some of the main takeaways. First, some points on selection and study design. Patients with EGFR amplified glioblastoma IDH wild type were recruited for the study, and consents for apheresis as well as apheresis collection were obtained. The presence of IL-13R alpha 2 was not required as a study inclusion criterion, owing to the lack of a validated assay for detecting and/or quantifying its expression. Patients received the standard of care therapy, and upon disease recurrence, screening and main consent were completed. Continued eligibility was confirmed thereafter, and then patients underwent resection/debulking surgery and concomitant Ommaya reservoir placements. Patients were imaged with MRI post-Ommaya placements and immediately pre-CAR T cell therapy. Patients were also randomized to one of 3 treatment arms, and the study treatment was delivered intrathecally through the Ommaya reservoir. The primary endpoints for this study were dose-limiting toxicity, determination of the maximum treatment dose and recommended dose expansion, as well as occurrence of adverse events. Only 1 patient met criteria for dose-limiting toxicity. The maximum treatment dose and recommended dose expansion was established as 25 million cells after analysis by the medical director and principal investigator. Finally, grade 1 and 2 cytokine release syndrome occurred in all patients, and all patients experienced neurotoxicity related to the CAR T cells. These neurotoxicities were all effectively managed using dexamethasone and/or anakinra, with some patients only requiring supportive therapy. By the completion of the phase 1 trial, 62% of patients in the extension study experienced tumor regression. Of these 8, all had experienced progression of their disease on the immediate pre-CAR T cell MRI scan relative to the postoperative MRI scan from the Ommaya placement surgery. This highlights the impact of the treatment on the trajectory of the disease. The time points shown here include the postoperative MRI scan taken on postoperative day 1 following the surgery that was performed for maximal safe tumor resection and Ommaya reservoir placements, the immediate pre-CAR T MRI scan taken within 1 to 2 days prior to the CAR T cell infusion, and a 1-month post-CAR T MRI scan. No anti-cancer therapies were administered between scan 1 and 2, and no anti-cancer therapies other than the CAR T cells were administered between scan 2 and 3. T1 post-contrast MRI images for patient 28 confirmed a partial response, which was the best response achieved by the modified response assessment in neuro-oncology criteria. Patient 26, who also experienced marked tumor regression of a large enhancing tumor in the splenium of the corpus callosum, eventually had tumor progression 1 month later. Finally, in patient 7, an increase in enhancing tumor on 1-month MRI was followed by spontaneous tumor regression on the 2-month MRI, consistent with pseudoprogression. At the time of data cutoff for response assessments, 15 of 18 patients had experienced progressive disease, 1 patient died without progressive disease, and 2 patients remain alive and free of progression. Analysis of all patients showed varying levels of CAR T cell DNA in the CSF by treatment dose, with the highest levels of CAR T cell DNA observed in dose level 2, who received 25 million cells. Of note, T cells spiked in all groups immediately post-infusion, reached their peak between days 4 and 10, and subsided to baseline levels around month 2 post-infusion. CAR T cells were also found in the peripheral blood, indicating a possible communication between the CSF and peripheral blood compartments. Dose level 2 showed the highest number of T cells in the peripheral blood, and return to baseline numbers was seen in all groups by month 3 post-treatment. Additionally, cytokine markers of T cell activation, like interleukin 2, tumor necrosis factor, and interferon gamma, all showed exponential increases in expression immediately post-treatment, with a return to baseline levels by 1 month. This study presents data on the first in-human trial of bivalent CAR T cells targeted against EGFR epitope 806 and IL-13R alpha 2 for recurrent glioblastoma, and demonstrated a tolerable safety profile while showing encouraging signs that cells are bioactive and exert anti-tumor effects. The study also showed that intraventricular delivery of CAR T cells is feasible, and T cell levels spike immediately post-treatment and persist within the CSF for up to a month at maximum treatment dose. Finally, neurotoxicity was prevalent amongst all study participants, but this was effectively managed with dexamethasone and anakinra. And as the study progressed, more patients were managed supportively without dexamethasone or anakinra. These advances in CAR T cell therapy have understandably created a lot of excitement amongst patients and the scientific community. And building on that, I wanted to review another exciting innovation in CAR T cell therapy, which is in vivo production of these CAR T cells. Ex vivo CAR T cell production is the current industry standard for FDA-approved therapies, as well as the vast majority of research trials. And this consists of leukapheresis from patients, followed by T cell isolation, T cell transduction, and T cell expansion with or without chemotherapy preconditioning before CAR T cells are infused back into the patients. This process is expensive, with currently FDA-approved therapies costing around $500,000 for a vial. This process is also logistically complex, as most of the isolation, transduction, and expansion can take several weeks and requires a separate facility with only a relatively small number of medical centers offering this treatment nationwide. This in turn creates delays and long wait lists for patients. Cytokine release syndrome, otherwise known as CRS, and immune effector cell-associated neurotoxicity syndrome, otherwise known as ICANS, are well-documented toxicities of ex vivo CAR T cell therapy that can be life-threatening and require management at specialized centers. While the immunosuppressive environment of solid tumors plays a role in T cell exhaustion, studies have found that overexpression of calcium signaling and prolonged interleukin 2 stimulation during ex vivo expansion of CAR T cells can lead to terminal differentiation and T cell exhaustion even before treatment. In vivo production appears to hold some promise for remedying some of these challenges. In vivo production, a CAR-producing viral vector nanocarrier is injected directly into the patients, and the T cells are transduced or transfected and expanded within the patients without any need for leukapheresis. And some early studies in liquid tumors, including from investigators here at Penn, have shown early signs of efficacy. In vivo CAR T cell production offers a paradigm shift. By injecting a CAR-encoding lentiviral vector or mRNA-expressing CAR packaged within lipid nanoparticles directly into the patient's T cells can become CAR T cells basically on site. This could reduce costs dramatically and could potentially turn CAR T cell therapy into an off-the-shelf treatment. In vivo production could be an order of a magnitude cheaper than ex vivo. Currently, the vein-to-vein time that spans time from leukapheresis to reinfusion of transduced CAR T cells in ex vivo production is anywhere between 3 to 6 weeks. With in vivo production, patients could receive CAR T cell therapy almost immediately without the manufacturing bottleneck or delays. Furthermore, because gene vectors target existing T cells in the patients, preconditioning chemotherapy could be avoided. Patients too frail for chemotherapy could still receive therapy and more robust immunity could be preserved. Finally, in vivo CAR T cells could be given repeatedly, like a vaccine boost, potentially maintaining anti-tumor immunity longer. Overall, in vivo CAR T promises faster, cheaper, and potentially safer therapy. First of all, I would like to acknowledge Dr. Stephen Brem for his graceful mentorship throughout my neurosurgery subspecialty clerkship and for his guidance and input in creating this presentation. I would also like to thank all the neurosurgery faculty who were gracious enough to invite me in to scrub, learn, and get involved with their cases during my clerkship. Finally, a special thank you to the chiefs, fellows, residents, APPs, and sub-Is who I had the most face time with and who ensured I had a fun and a great educational experience. Thank you all so much.